Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration.
Hi, my name is Joe Passaro. I'm a general dentist, but my practice is dedicated to comprehensive restorative and aesthetic dentistry. And really, if you can take a patient that has no teeth and make them aesthetically and functionally perfect, you can do anything with patients with teeth. Our greatest accomplishment has been the development of our dental family. These ladies rock. It's a pleasure to go to work. Besides the two old guys in the front of this picture, there's over 140 years of service to our practice. And really, what we feel is that you have to develop and continually refine systems in your practice to succeed. So the system that we developed for treatment planning is called STEP. And the STEP process is going to work for dentate patients and denture patients. So let's run through a patient. This is George. And we're not going to talk about impression-taking techniques. We're not going to talk about border molding. We're just going to talk about where do the teeth belong. And we're going to need some type of reference point to start with. Typically, that's an occlusion rim. And I don't like occlusion rims. I never had great success with them. To me, it was just to spot the marked midline, try to figure out where the central incisors were. Doing a phonetic evaluation of a patient with an occlusion rim is just a complete waste of time in my mind. So we've developed something different, and what we do is we make an anterior setup. We use the 10-20 rule for the maxillary teeth and the 18-millimeter rule for the mandibular teeth. And what you can see in the bottom left-hand corner of the screen is an instrument called an Alma gauge. And the tip of the Alma gauge is going to fit to where the incised papilla would be on the record base. And if you take a bunch of study casts off the wall in your lab and you measure, on the average patient, the incisal edge of the central incisors is 10 millimeters. The AP distance from the incised papilla to the central incisor is 10 millimeters. So that's what we're going to do. We're going to build the occlusion rim out to 10 millimeters. And then the height, the general height of the maxillary vestibule is 20 millimeters. And we're going to make so you see that on the lower right-hand corner. And we're going to make that there. Now, what we know is that when the patient loses teeth, the maxilla is going to resorb, but it's going to resorb posteriorly and superiorly. The incisive papilla stays in the same spot. So it's a great reference point. And these are the maxillary and mandibular anterior setup. So I don't get an occlusion rim back. I get this back. It's set to anatomic norms, and sometimes, if you're having a real good day, it's like perfect. But in our practice, we're almost always tweaking them because we're looking for perfect. And these are just anatomic norms. So now I happen to be into efficiency and delegation. I love the ladies I work with. They are all superstars, and I'm basically lazy. So I delegate this to either Michelle or Lacey. The patient will come in. They'll fit these anterior setups in. They will check for sore spots, remove any sore spots. If they need a little adhesive, they'll put adhesive in. And they'll sit and they'll talk with the patient, and they have to engage patient conversation for at least 15 minutes. What I'm looking to do is I'm looking, first of all, for them to get used to having these anterior teeth in so I can evaluate their phonetics, and also their lips are going to start to relax after they've been in. At first, they're a foreign body. So if you're trying to evaluate the aesthetics and the phonetics as soon as you put them in, it's a waste of time. So I let my assistant do that while I'm doing other things, and I walk in the room after 15 minutes. And what I'll do is I'll engage George in conversation, and I'll start getting a sense for how they look and how they feel. So once we get this done, we're going to start our aesthetic analysis. Okay, and what we need for the way we figure out aesthetically where the teeth belong is that we apply definitive aesthetic parameters to photographs using our digital template. That's our step process. And so we're going to apply that to George. And the first thing we need are photographs of George. And the photographs have to be coming in at precise angles. If the angles are off, the diagnostic information is not true. So we're going to take those pictures from precise angles, and then we're going to dump the pictures into our PowerPoint template. This is our step PowerPoint template. As you can see, it has lines. There's prompt boxes that direct the aesthetic analysis. And we're going to start analyzing how we're doing with George in the anterior setup. So in this profile shot, you can actually see we break him into facial thirds, from the bottom of the chin to the base of the nose to the glabella, and glabella to the hairline, which is sometimes arbitrary. But we're not worried about the top third of the head, because we're not going to do anything to that. We're just going to worry about the middle third and lower third. Are they approximate? And you can actually see the lower third might be a tiny bit bigger than the upper third. This is giving us an idea of the vertical dimension, and do we have him at an appropriate vertical dimension? And then the full face smiling shot is going to analyze a few things. First of all, we crop the photo to line his head straight up and down, drop a line down the center of his face, and that's going to give us a midline. And then the perpendicular at the incisal plane is going to tell us if we're canted left or right, if there's any kind of cant to the incisal plane. So this is all information that we can get from taking our photographs. And when you sit and look at it, you start really seeing things that you don't see when you're just engaging the patient conversation or leaning over the front of the chair looking at the patient. Then the profile shots are also just great information. We can see on the left side, we're going to evaluate his nasolabial angle that we want somewhere between 85 and 105, and that's looking pretty good. And then even the proclination of teeth and his smile. So I'm starting to feel pretty good about, man, this setup is pretty close. You know, we're looking good with George. So now we'll go to our teeth apart, lips at rest, and high smile photographs. And you know, we're trained to find things that are wrong. That's just what I feel I do. I look for things and I try to find things that are wrong with patients. So my first idea there is that his left canine, maxillary left canine, is hanging up on his lip. And I don't like that. I'm going to want John to tip those in a little bit. And I'm also thinking there might be a slight cant to that incisal plane. So the way we're going to check that is we're going to take that full face photo that we took before with the lines on it, and we're going to crop it real tight to the mouth, and we're going to analyze the line very closely. Now this picture will get a little pixelated, but it still has valuable information. And when we look at that, you can actually see that the left canine there's a tiniest little bit of cant to the incisal plane. I'm telling you, I'm picky. That's all there is to it. And John, my technician, he's picky. We're going to want to bring those in a little bit. Okay? So now the other things that I'm seeing when I look at this is the fact that the lower incisal plane looks like it might be a little canted. And I like his right side, the patient's right side, better than the left. I think the teeth on the left side are up a tiny bit. So I'm going to want John to fix that cant also by dropping the canine on the left side. You can even see it in the smiling photograph that the space between the maxillary incisal edges and the mandibular incisal edges is opening as you go to the patient's right. So by lowering the left canine on the bottom and raising the left canine on the top, we should be able to level that out. I like those incisal planes to be real level. Finally, what we see at the lip at rest shot is the fact that we don't have any incisal edge display. Several photos ago, several slides ago, we had a shot with the ruler under George's lip. The ruler was turned at a 45-degree angle, and touching his lower lip, and we could see that those incisal edges are actually 2 millimeters under the edge of the lip. I typically want to show a little bit of incisal edge. But another shot that we take is the ruler from the base of the nose to the edge of the lip. And the average lip length for a male is 22 to 24 millimeters. Okay? So George being older, and the older we get, the longer that lip gets, it usually should be about 24 millimeters, and he's 31. So I'm not sure if we're going to get that edge, and it's also going to depend on how he feels about it. If he wants a toothy smile, if he doesn't want a toothy smile. These are just factors that are all put into. You can never say, I always show 2 millimeters of incisal edge. There's all these factors that would come into play when deciding where we want to position the teeth. So now we're going to take, and there's that ruler showing the 2 millimeters under the lip. So now we're going to take the mirror out, and I'm going to talk with George. So you have to realize that I haven't been in the operatory. I've been other places. Michelle's been in there, or Lacey, and they've been chatting with the patient. I walk in, I chat for a few minutes, I try to make George laugh so I can see what happens with the tooth display. I'm getting a pretty good sense of what's going on with him. And now I'm going to show him the mirror and let him see the teeth. If this anterior setup comes back from the laboratory and I put it in the patient's mouth and it's like, ooh, that looks ugly, I'm not showing it to the patient. We're only going to show it to the patient if we're close, if we're in the ballpark. I don't want them to get an idea that, they're just anatomic norms. And I explain that to the patient when that happens. I say, look, these are just set there by anatomic norms, and they don't look nice. But it does give us a reference. We still take these photographs, and then we're going to send the photographs off to John. John Zarb is my technician. John is a phenomenal denture technician, unbelievably precise, and he's just a pleasure to work with. And that's one of the bases of our practice. We have a relationship practice. If a technician is phenomenal, but they're a pain to work with, I'm not working with them. John is a great technician, Master Dental Prosthetics, Watkinsville, Georgia. John is the best. So what we're going to do is I'm going to take my PowerPoint that we've made. The photographs have been cropped by my assistant. Remember, I don't do anything. My assistant crops the photographs. She puts them in the PowerPoint. She puts the lines on the pictures. I just come in and check it. We're going to take the PowerPoint. I'm going to take a Facebook transfer of that upper setup, and the Facebook transfer is going to give John information of where the upper teeth are relative to the condyles. It's going to also be a second check on the incisal plane of the teeth, because the only thing we have is the pictures, and now it's got to make sense when he looks at that mounted case that what's on the lab bench is mimicking what we saw in the pictures. It's a verification step. So I'm going to send them the jig. The jig's also going to give them the Frankfurt plane. So we're going to have that parallel to the bench top, and we're going to send them a centric bite record and the PowerPoint. And the way this works, I have a half an hour of admin time every morning. And when I've got a case going with John, my ladies will set it up that I have a 10-minute conversation with John. One of my assistants sits in the room. She takes all the notes from my conversation. John, we want to tuck those canines in. We want to do this. We want to do this. What do you see? How are you going to do it? So on and so forth. And that's the way that goes. The assistant takes notes on all of that, and her notes get put on a separate slide of the PowerPoint. Because what happens is the PowerPoint becomes documentation of exactly how we're doing the case. This is the way the anterior setup came back. These are the changes we wanted to make in written notes. Then when we send the case to the lab, John mounts it on the articulator, and now we have the posterior teeth put in on the maxilla. I leave a bite block in the back on the mandible because I'm going to recheck the bite registration when he comes in. So this becomes the way we work the case. Now, if I was looking to get this case done as fast as I could, I might be able to just have John make those few changes. Tuck the canines in, cant the incisal plane, or take care of the cant or the incisal plane on the maxilla and the mandible. The bite looked good. They just process them and send them in, but we're picky. So this is going to come back to my office, and we're going to do the same process because that process doesn't really take much of my time. George is going to come in. This time he won't have any sore spots on his record bases. There will be no adjustment because they're the same record bases. Put a little adhesive if we need to. Michelle will talk to him for 15 minutes, and then I make my appearance in the room, and I spend more time shooting the breeze with George than I do doing any dentistry. I'm just evaluating the teeth. Then I'll take my pictures. Lacey will crop them. Lacey will put them in the PowerPoint, goes to John, and that's the process. So this is the way George ends up, and the same process that we use for making dentures, we use for making teeth. If we're doing a veneer case on a patient with a lot of wear, we're going to take the pictures, we're going to analyze them, we're going to draw our lines in the pictures, and we'll know where we're going with the case. And then once we put the provisionals in, we take the same set of photos over again, we reanalyze the photos, and we're good. So here's a key point. Ideal tooth position is determined by aesthetics and function. Okay? Denture teeth, natural teeth. We just have to get the teeth in the right position aesthetically first, then we take our bite registration and we figure out how to make the bite work, how to make the teeth fit when the teeth are in the right position. And I can tell you, if you get the teeth in the right position aesthetically, I've never seen a case where I've had the teeth and I feel like they're really in a good spot and the patient has problems with phonetics. The phonetics just works itself out. This is our occlusal, our checklist of aesthetic parameters. We start with the face, just like we did with George. We look at the face, midline, incisal occlusal plant, then the dentofacial characteristics, lip length, incisal edge display, lip mobility, what's happening with the lips around the teeth, and what's happening with the lips around the teeth is related back to what we saw in the face. And then all the dental things like tooth proportions and gingival height of contour, those are all things that with dentures you don't have to worry about. The denture teeth are already at the right proportion. They're just coming out of the box the right way, and if the technician's putting the pink around the teeth properly, all the gingival things are correct. So in closing, I want to share some feelings I have towards one of my mentors, Jack Turbyfill. Woody and I weren't interested in making dentures. Pete Dawson had talked to us about taking Frank Spear's continuum out in Seattle when we got done. He said, I think you boys should go to Seattle, and you should also take denture fabrication from Jack Turbyfill. And Woody and I said, I want to make veneers. I want to make pretty teeth. I don't want to make dentures. But we ran into Turbyfill at a meeting, and we decided to take his course. And, Frank Spear is a genius. Everybody knows that. Jack Turbyfill is a genius also. He's just disguised as a redneck. He's a brilliant teacher. He's taught us so much about function. But the thing that he taught me the most, back in 2003, we were taking a course with him, and he said, boys, I'm not going to talk about a lot of practice management things. I'm just going to tell you one thing. He said, when you're young, you think life is about things. And when you get older, you realize that life is about relationships. That was in 2003. Woody and I, on the plane flight home, sat down. We have a practice vision that we review every year. And we pulled out our notepads and we said, look, let's look at our practice vision and really incorporate the word relationship everywhere in that vision. And we did. And I can tell you it's made a tremendous difference in our practice. So thank you, Jack. Thank you, Woody, for being my co-learner and partner of 36 years. And I hope I've been able to give you some tips on tooth position relative to the denture patient, but also that would apply to patients with teeth. Thank you.